Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about screening for breast cancer with Dr. Ilana Richman. Dr. Richman is an assistant professor of internal medicine at the Yale School of Medicine. Here's Dr. Weiner.
Before we get going, I almost always do this. Tell me a little bit about you. Where you're from? How did you wind up in New Haven?
So I actually grew up in upstate New York in a small town, not all that far from New Haven. I went west for all of my medical training. I did my medical school at UCSF in San Francisco, and then I went south to Stanford for internal medicine training, and I stayed on for a few more years to be a chief resident and to do additional training in health services research, which is essentially using the tools of epidemiology and economics to understand health outcomes. And then I came back to New Haven, or to the East Coast, in 2017 for job opportunities. So that's what brought me here.
So you've been here for 7 years, roughly.
Yeah.
Your interest is primarily on cancer screening. Is that right?
Yeah, that's right.
And figuring out how we can do it in the most effective way, and looking at both the upsides and the downsides.
Yeah, that's exactly right.
Okay, so why don't we just jump in? And of course, the probably screening test that the greatest number of people are familiar with is mammography, and a very, very commonly used tool. Mammography has been in use now for well over 30 years. Maybe first you could just comment on the kinds of studies that were done early on that led to the use of mammography, and how it became such a part of everything that we do.
Mammography actually has been around for almost 100 years. It was, I guess, more than 100 years. It was around the 1920s when people first understood that you could take an X-ray of the breast and detect something. But it wasn't until about the 1960s that people really started to think about systematically screening women. Screening meaning doing an X-ray of the breast, a mammogram, in women who were asymptomatic, did not feel any lumps or bumps, and trying to look for breast cancer early. And so beginning in the 1960s, there were a series of landmark clinical trials that randomized women to screening or usual care, which might include no screening or clinical breast exam. And then those studies followed women for many years after to understand whether using that screening test, doing a mammogram, reduced the risk of dying of breast cancer. And so what those studies found is that indeed there was a reduction in the risk of dying of breast cancer among women who were randomized or who got a mammogram in those studies. And so those studies, again, which were done between the 1960s and the 1990s, form the basis of our current practice. It's those studies on which our current guidelines are based, and that's why we do what we do. It was really based on those early studies, which were completed now decades ago.
And how big was that benefit?
So across those studies, when you put them all together and kind of add them all up and take an average, screening mammography appears to reduce the risk of dying of breast cancer something like 20 to 30%, depending on the specific age group and population. And
just to be clear, that 20 to 30% isn't an absolute 20 to 30%. It means that if a small proportion of the population dies of breast cancer, of that number, it's a 20% reduction, correct?
That's right. It's in absolute terms. You could think about it this way. If you have a population of 1,000 women, the lifetime risk of breast cancer is about 12%. So about 120 women will develop breast cancer in a group of 1,000 women. If you screened all of those women without fail over their lifetime, you might avert something like 5 to 8 breast cancer deaths in that whole group of 1,000 women. So 120 will be diagnosed with breast cancer, but only a handful will actually have their breast cancer death averted by screening. Many other women will also benefit from treatment, but the screening itself probably only reduces breast cancer risk of breast cancer death by a fraction.
And that's because some women, in spite of screening, unfortunately, will still lose their life from breast cancer. And because many women who are diagnosed a little bit later and who didn't have the diagnosis as a result of screening will also do extremely well.
That's right. That's right. So we have excellent treatments, which sort of counterintuitively mean that screening is less important. Like the better a treatment is, actually the less important it is to diagnose a disease early because we can do very well treating it. And then the second thing is that screening isn't perfect, both because we can miss breast cancers when they're actually there. So the test sometimes doesn't pick up breast cancers that are developing early, but also because we screen at intervals every 2 years, say, or every 1 year even. And sometimes breast cancers arise in that interval that we don't catch.
And of course, one approach has been to try to come up with better screening tools. So initially, mammography was done with a relatively simple technique, and it has become somewhat more sophisticated over time. And then there are other tests too.
Yeah, there's been a evolution of the technology that we use over the past 30 years. So in the very beginning, we used plain film, which is literally like the kind of film you would have in a camera, where there's a negative that gets developed and you put it up on a light box and look at it. Around the 1990s, we transitioned to digital mammography. Digital mammography, the evidence was mixed, but one advantage of digital mammography is that the storage and sort of sharing of data is a lot easier. So, for example, if you go from one practice to another or have mammograms done over time, it's actually a lot easier to compare them. And that's a legitimate advantage of digital mammography. And the reality is all radiology is done digital these days. We're never going back to film. So we transitioned to digital. And then around the mid 20-teens, around 2015, we had the advent of digital breast tomosynthesis, which has become the predominant mode of screening in the United States. So digital breast tomosynthesis actually takes kind of multiple x-rays of the breast and creates this sort of 3D image that allows the radiologist to sort of maybe see more clearly what's going on in terms of distinguishing abnormal areas from normal areas. The evidence, the data around digital breast tomosynthesis, again, is somewhat mixed. Some studies have shown that it's slightly better at picking up early breast cancers, although not all studies have shown that. And other studies suggest that it's a little bit better at reducing false alarms, which I think is actually a real benefit. If there is a benefit of digital breast tomosynthesis, it's that it reduces false alarms, because that experience of having a false alarm is truly distressing.
And to what extent do you think that the widespread use of mammography is beneficial, partially because it just raises everyone's awareness of breast cancer and it encourages women to pay attention to their breasts, and if they at some point identify an abnormality, make sure they see their doctor?
It's true that concurrent with the advent of mammography, we have seen a decline in breast cancer mortality. By some estimates, about half of that benefit is due to treatment, maybe a little bit more in recent years, and the other portion of it is due to screening. The extent to which awareness has been sort of the driver, I don't know. That's actually a really interesting question, but I do agree there's a ton of awareness around breast cancer. And I think most, women in their lifetime understand that mammography is a kind of important preventive service that they should have, and it's perceived, I think, very positively. So there certainly is a lot of awareness.
So before we get into sort of some of the more controversial areas, Not that this hasn't been controversial at times, but could you just review the screening guidelines in the U.S. at the moment? And, in truth, there's been a lot of controversy over this. And for me, it's often felt much ado about not very much. Because whether you start at one age or a couple of years later, is probably not the major issue. But what are we supposed to be doing now?
So I'm a primary care doctor, and so we tend to listen to a group called the U.S. Preventive Services Task Force. The task force is an independent body of experts, actually usually not specialists or specifically not specialists, but generalists like primary care doctors who review the data in a transparent and systematic way and come up with recommendations. So the task force currently recommends that women 40 to 74 be screened with mammography every other year. And they say that digital mammography is fine, digital breast tomosynthesis is fine, and either of those two modalities is acceptable. They don't recommend doing annual screening, and they don't make a specific recommendation about screening after the age of 74. So once a woman is 75, they say that the data are insufficient to make a recommendation for or against screening. So those are the current recommendations. There are other recommendations out there. The American College of Radiology has recommendations. The American Cancer Society has recommendations. I agree. They're all kind of variations on this theme. Some are recommend a little bit more intensive screening, some less. If people have asked the question, if we followed one recommendation versus another, does it matter? And the answer is yes. If, for example, we screened everyone annually in the United States versus every other year, it would cost a lot more. And we might see small changes in health outcomes in one direction or another. But actually, the reality is that practice doesn't change very much in response to screening. So, in response to guidelines. So I agree with you. There's often a big sort of fuss and discussion about the guidelines, but when we look back and ask, well, do patients and doctors change their practice? The answer is not really.
Yeah, I will say that in my own view as a breast cancer doctor, I think that the Preventive Services Task Force has very reasonable recommendations. I think the ACS in general has slightly different, but also reasonable recommendations. And, there are a few choices, but they're just not that different from one another. So before we take a break, we have about a minute. And maybe you could just begin to touch on what we're really going to focus on, which is some of the potential harms associated with mammography, because the upside is you do prevent a small number of deaths, and that's important, but there are some downsides.
There are some downsides. So the most common risk of screening is a false alarm. And it's estimated that, for example, if we go back to screening 1,000 women over their lifetime, on average, women will have more than one false alarm. So like 1,300 false alarms will occur. Some women will have 2 or 3, some women will have none. But false alarms, bottom line, are very common. Sometimes they can be resolved quickly through, say, getting another mammogram or an ultrasound. Sometimes women need a biopsy. Even, I think, in the instance where a false alarm is resolved quickly, if you've ever yourself had one or known someone who's had one, like it's tough. I think there's a moment where people really start to worry, even if after a couple weeks, all is well. So that's the most common harm.
Yeah. And I think we're going to have to go to our break. But when we come back, we're going to keep talking about this issue of false alarms and potential harms and perhaps ways we can get around some of those difficulties.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their endocrine cancers program is one of the largest multidisciplinary programs in the country and is experienced in treating rare cancers. More at smilowcancerhospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
This is Eric Weiner with Yale Cancer Answers, joined tonight by Ilana Richman. And we're talking about cancer screening, specifically breast cancer screening. And we left at the time of the break talking about some of the harms associated with mammography, and in particular, when there are false positives, the emotional harms or the reaction. Ilana, do you think that it's possible to better educate our patients so that when in fact they get an abnormal mammogram, knowing that frequently it's a false positive, that we can somehow take the anxiety out of it? Or do you think it's just never going to happen?
I remember when I was in medical school, we learned about the test characteristics of mammography, it was part of our epidemiology curriculum. We were learning about these concepts around screening tests. And, among women who have an abnormal mammogram, only a minority will end up having breast cancer. Depending on exactly the findings, it could be between 5 and 25% will end up having breast cancer.
And a tiny number of those people will lose their life from breast cancer because it would be a very early breast cancer in the vast majority of cases.
That's
correct?
Right. That's right. And I remember, I distinctly remember sitting in the classroom. That blew my mind because I think I was much closer at that point in my life to being a layperson. I was just learning medicine. And I had no idea that a test that we routinely do could so commonly actually give the wrong answer. And I don't think patients understand that at all. And the truth is, I think even if you reassure patients, okay, most of the time this turns out to be nothing and we're going to figure it out in an expedited way, it's really hard, I think, to feel reassured until you know with certainty that there's nothing there. And so it is tough. I don't think we routinely talk about these things before embarking on breast cancer screening, which is interesting because it's different from other kinds of cancer screening where we have to talk about the risks and benefits. So, for example, lung cancer screening, we're required to discuss these aspects of it. But that historically has not been the case for breast cancer screening. And frankly, for many other kinds of screening, we don't kind of get into the nitty gritty. We just say, oh, looks like you're due, and we're going to send you off to get your test.
And you could imagine that in mammography waiting areas, there could be literature on, don't worry if we call you back kind of thing.
Yeah.
But I don't know that anyone has ever tried that. But you could imagine they could really help people a lot.
Yeah.
So beyond the psychological issues, what are some of the other potential harms associated with mammography?
The main other harm, and the one actually that got me interested in studying mammography, is this phenomenon called overdiagnosis. Overdiagnosis is a situation where we find disease, in this case, breast cancer, on screening that never would have caused harm in a person's lifetime. So that little focus of breast cancer would have lain dormant in the breast and never would have caused symptoms, never would have spread throughout the body. And we wouldn't have known about it had we not gone looking. But once we find it, we're usually obligated to do something about it. And that might mean getting surgery, radiation, maybe even other medications or chemotherapy to treat it. So this idea of overdiagnosis, I think, has gotten increasing attention in the screening world, but remains a challenge. The reason why it's a challenge is because we never know for any one individual whether their breast cancer is the one that's likely to take off and become life-threatening or not. We have, of course, some tools that we can use to prognosticate, meaning to say, like, this looks like a more serious or aggressive breast cancer, and this looks like one that's not. But even among the ones that we think are less aggressive, it's difficult to know for sure.
And a related concept, and maybe you could explain this to the listeners, is this idea of length time bias. And it clearly has has importance here because it affects the types of cancers that are preferentially found on mammography. So can you comment on that?
Yeah. So length time bias is a word for kind of a feature of screening that can increase overdiagnosis. So length time bias is where breast cancers that grow slowly and tend to be not particularly aggressive are the ones that we actually end up finding on screening because they're just sitting there in the breast slowly, maybe growing slowly or not even doing anything, not causing symptoms. And so when we do a mammogram, sure enough, that's the one we find. The breast cancers that tend to grow quickly, we don't find on mammography because they arise between mammograms, and then a woman might feel a mass or changes on the skin of the breast or something else that brings the situation to attention. So because we screen at regular intervals, say every 2 years, it sets up a situation where we might just end up finding the breast cancers that are least likely to cause harm in a woman's lifetime, and the ones that are more likely to cause harm we don't catch because we don't screen people every single day of their lives.
And that's probably related to the fact that mammographically detected breast cancer, so a woman who is diagnosed as a result of a mammogram, not because she felt a lump, fundamentally has a better prognosis.
Yeah, people have asked the question, when we know that when women are diagnosed with breast cancer on mammography versus symptoms, the women who are diagnosed by mammography tend to do better. And so you could interpret that in two ways. You could say that, the mammogram saves someone's life, or you can say the mammogram is actually detecting breast cancers that are better behaved, so to speak, less likely to cause problems.
Yeah. So you've done some, what I would call high profile and in fact, award-winning research that has focused on screening in older women and this idea of overdiagnosis that can arise, particularly in women who are over the age of, you tell me.
So I was interested in looking at overdiagnosis among older women because I think it's particularly relevant to older women. So I talked about how the behavior of a particular cancer might influence the likelihood of overdiagnosis. You can imagine breast cancers that grow very slowly and just kind of hang out. Those are the ones that are likely to be overdiagnosed. But the other piece of it is that the patient's own factors also play a role. So for a young woman, someone in their 40s, they have a very long life ahead of them, hopefully. And so even a slow growing breast cancer over the next 30 or 40 years could cause a problem. In a woman who's already 80 years old, if it's going to take 30 years for that breast cancer to cause a problem, most women who are 80 don't live another 30 years. And so this piece of life expectancy also plays a role. And so for that reason, we were interested in looking at overdiagnosis among older women and actually trying to quantify it. And again, I think the reason why quantification is important is because overdiagnosis, I think most people acknowledge exists as an issue. But how problematic it is does, I think, depend on how commonly it occurs. So if it's 1 in a million women, maybe we don't have to worry about it. But if it's 1 in 100 or 1 in 1,000, like those risks are higher. So quantifying it is important. So we used some epidemiologic methods to try to understand the risk of overdiagnosis among older women. And what we found, as you might expect, is that for women who are older or who have limited life expectancy because of, say, other serious health problems, the risk of overdiagnosis increases. And just to put a number around it, so we found, for example, that among women with a life expectancy of about 5 years or less, so these might be women who are in their upper 90s or even younger women who have other serious health conditions, more than 60% of breast cancers that were found on mammography were likely overdiagnosed. For younger women, say a woman in her 70s who's relatively healthy, that fraction is a lot lower. It might be only 30%. So it really does depend on the individual, their age, and their other health conditions.
So as a primary care doctor, does this help inform you when you're seeing a 72-year-old woman versus an 86-year-old woman when you talk about mammography?
Yeah, absolutely. I think a goal of primary care is always to try to tailor our recommendations to the person, not only their health conditions and their kind of their age, but also what is important to them. And so all these things, I think, come into play when we're having conversations around something like screening. But yes, for sure. I mean, I would feel much more comfortable telling a woman in her mid-80s with other serious health problems that I don't think a mammogram is likely to extend her life, likely to be helpful, than a woman, say, who's 74 and in excellent health.
But getting people to stop doing tests sometimes is tough. I remember that my mother refused to get mammograms when she was in her 50s, and I finally told her that it would be very embarrassing as her son, the breast cancer doctor, if in fact she were diagnosed with an advanced breast cancer and never had been screened. So she finally started. But then when she was 85, she wanted to continue. And I think it's hard for people.
It is hard for people. And it's hard for reasons that make a lot of sense and are hard to untangle. I think as people age, nobody wants to feel devalued or feel like they're not, their life isn't important or they're not worth, getting a test. And I think that the reality is that that's actually sort of the wrong question. We don't stop doing mammography because we're trying to save resources or because we don't think older adults are worth it. It's because the tests really are legitimately not helpful and potentially harmful.
Yeah,
so,
and I was just going to say, and the challenge at the moment is that so many primary care doctors have so little time to deal with all the medical problems that someone may come in and need to talk about, that there just isn't the time sometimes to really go into the explanation that would make someone very comfortable.
I agree with that. And so I think what happens often is that there's no discussion, which might be okay. Maybe it's okay to just kind of let some things drift away. But I think most people feel like if there is a medical decision to be made, they want to be a part of that decision. But it's challenging because there really isn't always time. And I think a lot of doctors often feel like they don't really even have the tools or the words to, broach these conversations.
And of course, the problem with overdiagnosis isn't the diagnosis itself, it's what we do with it. And so as clinicians, we need to become wiser about which diagnoses we can safely not pursue with any kind of aggressive treatment. And that, of course, is going on in the area of prostate cancer, where increasingly there's a group of men with prostate cancer who are being watched when they find that they have a very low-grade, early-stage prostate cancer.
Yeah, I think that's the dream, is if we were able to better prognosticate for women who are diagnosed with breast cancer, we could tell some women, hey, this is something we can safely watch. And for other women, this looks like something that we need to deal with in a different way. So, and actually my research group has done some work talking to older women about overdiagnosis and the concept that you could be diagnosed with a breast cancer that never would have become symptomatic is challenging for people to understand. I think often not a very convincing reason to stop screening. But what we have heard from women is that if my doctor could say, hey, I feel comfortable keeping an eye on this, we can do a mammogram or an ultrasound, or we'll watch it every year, but I don't think we need to worry about it. People understand that idea and often are on board with it.
Dr. Ilana Richman is an assistant professor of internal medicine at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.